be able to give this topic on to disclose, and I would like to start with some clinical cases. So our first case is George. He's an 11-year-old boy. He's been complaining of poor attention for the last 3 months, falling asleep in the middle of class. He's less motivated. Mom also states that he's grumpy, he's easily distracted. There are no other associated symptoms. He's not on any new medication. His Epworth sleepiness scale is of 10. His bedtime routine is as it's shown, which seems to be appropriate for his age. Our second case is John. He's an 18-year-old boy. He's complaining of excessive daytime sleepiness for the last 4 months. He also has mood changes. He denies any snoring, nocturnal apneas, restless sleep, any symptoms suggestive of cataplexy, hallucinations, or sleep fragmentations. There's no medications, and his Epworth is 12. His sleep schedule, his bedtime is at 10:30, wake up at 7:30 during the weekdays, and during the weekends he sleeps in until 11 a.m. after going to bed after midnight. Our third patient is Jane. She's a 40-year-old female that has been complaining of feeling tired and fatigued for the last 9 months. She says that if she has the opportunity, she will fall asleep very easily. Her husband has heard her snoring, but he denies any apneas. He states he's also a pretty heavy sleeper, so he didn't hear any apneas. No other associated symptoms either. Her Epworth sleepiness scale was 10, and she has an appropriate bedtime routine for her age, as we see. And our last case is Alexa. She's a 10-year-old girl who's been having extreme daytime sleepiness for the last 5 months or more. She has been falling asleep in class, and she falls asleep even in the middle of a conversation. There are also some episodes that she's been experiencing for the last 2 months where she will fall asleep to the ground. She's been seen by a neurologist for possible seizures and even by a psychologist for possible malingering. Alexa also states that she has very vivid dreams. She wakes up feeling scared, paralyzed. She sees and hears things that are not there. She does not have any restless sleep, and she wakes up frequently through the night. Her Epworth sleepiness scale was 18, and her bedtime shows that she sleeps like 11 hours through the night. And in addition to that, she takes at least 1 to 2 naps every day, lasting 1 to 2 hours a day. So what do all of our patients have in common? Alexa, John, Jane, and George. Well, they all have excessive daytime sleepiness of Hypersomnias. But what is excessive daytime sleepiness? This is defined as the inability to stay awake and alert during the major waking time of the day, resulting in periods of irrepressible need for sleep or unintended lapses into drowsiness or sleep. This sleepiness may vary in severity and is more likely to occur in boring, sedentary, and monotonous situations that require little active participation. So sleepiness is associated with large increase in total amount of daily sleep without any genuine feeling of restoration. So we characterize EDS by happening daily or almost daily, being chronic and pervasive, and as we described, is causing these irresistible needs of sleep. To evaluate hypersomnolence, we need to be familiar with the standard sleep time required based on age. The American Academy of Sleep Medicine and the Sleep Research Society developed a consensus recommendation for the amount of sleep needed to promote optimal health in adults using a random research and development appropriateness method process. So it recommends that adults sleep at least 7 or more hours per night regularly to promote optimal health. There are different diagnostic tools we use to address excessive daytime sleepiness. An accurate history is critical. So we have to evaluate if the patient is really sleepy or tired or has other symptoms like dyspnea or fatigue. We have to ask, when did the excessive daytime sleepiness started? Is this getting worse? Does the patient has other associated symptoms? Does our patient have any other medical disorder that could explain better the symptoms? Are there any new medications or substance added to the patient daily intake to explain the patient's complaint? And of course, our physical exam, we need to evaluate for signs of other medical conditions that could explain our patient's symptoms better. For example, a patient who is overweight with a thick neck and a crowded posterior oropharynx will guide us towards an obstructive sleep apnea diagnosis as the etiology of the EDS. All patients should be required to fill a sleep diary while being evaluated for hypersomnolence. The Epworth Sleepiness Scale is a subjective, patient-reported 8-item questionnaire intended to measure a general level of daytime. However, he did mention that he has been using more media every night after his birthday when he get a video game. So what the actigraphy study shows is really his accurate bedtime. We can see here that he's not been going between 10, as he mentioned, but after midnight during the weekdays. So he's been sleeping for 5 to 4 hours during the weekdays and then just trying to catching up during the weekends by sleeping in. So once we disclose this to the parents, the new video game that he got that was keeping him up during the nighttime was only allowed to be used during the weekdays. Once the stimuli was removed, then he's back to be quite himself. All these criteria must be met in order to make a diagnosis of insufficient sleep. And George did have all of them. He had behavioral changes. He was sleeping for more than 3 months. And we were able to document this by actigraphy. And again, once we removed the stimuli, which was the video game, he was able to go back to himself. So children with insufficient sleep may paradoxically present with inattentiveness, lack of concentration, decreased performance in school, emotional lability, depression, anxiety, being more defiant, irritable, and having hyperactive behavior. And in young children, sleepiness may express itself as a prolonged night of sleep or with the occurrence of a previously discontinued daytime napping. Lisa Metzel and Jody Mindell published this data in 2006, and we can see the significant discrepancy between the recommended and the actual sleep time duration that children are getting. So this data goes in favor that the most common cause of hypersomnolence in pediatric population is sleep deprivation. So the effects of insufficient sleep have been widely studied and are proven to affect our cardiovascular, neurocognitive, immune, endocrine, and musculoskeletal systems. We can see in this graph the effects of varying doses of nocturnal sleep time on lapses of attention from the psychomotor vigilance test. So the first panel from Van Dungen and others involved experimental sleep restriction on 36 healthy adults for 14 consecutive nights. So in the experiment, sleep was restricted for 14 nights, and subjects were randomized to 4 hours time in bed, 6-hour time in bed, or 8-hour time in bed. The psychomotor vigilance test performance was then assessed every 2 hours, 9 times each day, like from 7:30 to 11:30 p.m. The graphs show systematic increase in lapses of sustained attention when the sleep was restricted to either 4 hours or 6 hours, but not when sleep was restricted to 8 hours per night. The increase in lapsing was worse in the 4-hour sleep condition than in the 6 hours, further supporting a dose-response relationship. The horizontal dotted lines show the level of lapsing found in a separate experiments when subjects had been awake continuously for 68 and 88 hours. In the panel B, we see comparable sleep restriction data from Belenki and others, and in this study, sleep was restricted for 7 consecutive nights in 66 healthy adults. They were randomized for 3-hour time in bed, 5-hour time in bed, and 7-hour time in bed, or 9-hour time in bed. So the performance was assessed 4 times each day from 9 a.m. to 9 p.m. In the psychomotor vigilance test, lapses increased steadily across the days in the 3rd-hour and 5-hour restriction conditions. But not lapses was reduced in the 7-hour conditions. As in panel A, the horizontal dotted line shows the level of lapsing found in a separate experiment when subjects had been awake continuously for 64 to 88 hours. Considering then the data of both panels, panel A and B, it is clear that restriction of nocturnal sleep time in less than 7 hours per night in healthy individuals results in significant increments in lapsing of waking attention that gets progressively worse across days in a dose-response manner. Sleep is central to the development and optimal functioning of the brain. The CDC has declared insufficient sleep as a public health problem. Indeed, according to a recent CDC study, more than 1/3 of American adults are not getting enough sleep on a regular basis. This is from another article that we're going to talk more in depth, but it shows that 7 of the 15 leading causes of death are linked to insufficient sleep, and we have to include cardiovascular, cancer, cerebrovascular disease, accidents, diabetes, septicemia, and hypertension. So sleep plays an important role in determining cognitive performance and workplace productivity. And lack of sleep can lead to more traffic accidents, industrial accidents, medical errors, and loss of work productivity. And that's what this article shows. So we know that more than a third of American adults are not getting enough sleep on a regular basis. However, insufficient sleep is not exclusively a US problem and equally concerns other industrialized countries such as the United Kingdom, Japan, Germany, or